Bismillahirrahmanirrahim. So, Assalamualaikum everyone. I am Dr. Mubashira, and basically I have arranged this class, and the basic purpose of this class is to teach everyone the basics of neurology. The class is aimed not only for PACES candidates, but also it will be equally beneficial to the FCPS as well as MRCP and MD candidates. I just want that at the end of this class, you people should have a good knowledge of neurology, at least the basics of neurology, and how to approach the short cases of neurology. You should understand the command which is given to you in your examination, and also look for the type of lesion. You should localize the where is the lesion and find out the cause of the lesion during your 4, 5, or 6 minutes examination. At the end of this lecture, I will show you some videos of certain patients, and any one of you can participate and tell the positive findings and the possible diagnosis. All right. So, Dr. Faiza, am I audible?
Yes, Dr. Mubashira, you are audible.
And my voice is clear. So, let's start our class today. So, I would say the most important step in any exam, in any clinical exam, and the most important step towards your success in the exam, it is that you should know your exam and you should know your enemy. I think Dr. Faiza has got muted. Just wait. Actually, what happened, I mute everyone so that I can't do it during my presentation, because this class is a presentation based class. Once I would start the presentation, I can't mute anyone, because there are certain people who join the meeting and their camera is on, so there is kind of disturbance during the class. That's fine. So, Dr. Faiza, are you listening now?
Yes, Dr. Mubashira, I am listening.
Okay.
Your voice is clear, but some people are saying that your voice is a little low. Maybe it's connection problem on their end, because to me it is clear.
Actually, I have changed my headphones today and I checked it multiple times. I think it should be clear now. Let me check the chat.
Yes, it's.
When I will start the class, I may not be able to see the chat messages or something like that. So anytime if my voice get down, please tell me.
Okay, Dr. Mubashira, about the messages.
Okay. So, so let's start. So I was telling that the most important step towards your success is in exam, especially in the clinical exam, is that you should know your exam and you should know your enemy. Here, know your exam means that what you should do in order to succeed. And know your enemy means that what you should not do in the exam. It just means that do's and don'ts of the exam. Here, the enemy doesn't mean that, for example, the examiners are your enemy, because there are certain candidates who performed somewhat different from you or somewhat different from other candidates. That's why they got passed. All right. So, I want to make sure that anybody who is listening to this class, I just want that all of you succeed. And inshallah, you all will be successful. Okay. So, when I was saying know your exam, here there are common commands which come in the exam. For example, in the neurology short case, whatever exam you are giving, any clinical medicine exam, always there are certain commands. The most common command is lower limb examination, then upper limb examination. It can be cranial nerve examination, or even you can get some weird command. For example, look at the patient, examine neurologically. Okay, so you should be prepared for any of the command. All right. This third point you can see on the screen is that, Dr. Faiza, my screen is visible now. Okay, so this third point, this command has come in certain FCPS exams. And let me tell you, if you don't know this command, immediately when the examiner will give you this command, you may get puzzled because all of us are not prepared for such weird commands. But once you know, you will not get puzzled. Instead, the examiner may get puzzled that how this candidate know about such deep things of neurology. So what these commands can come. For example, examine the first six cranial nerves or examine the last six cranial nerves starting from the seventh towards the 12th cranial nerve. Or it can come examine the motor cranial nerves or examine the sensory cranial nerves. If you know what are the pure motor cranial nerves or what are the pure sensory cranial nerves or what are the mixed nerves, then it is not difficult for you. All right. So the pure motor cranial nerves are cranial nerve 3rd, 4th, 6th, 11, and 12. For example, you will start from the checking the eye, edge movement, visual field, and then you can go towards the tongue, and then you can check the 11th nerve, abducent nerve. But as you know that you can complete this examination within the 2 minutes. After that, the relevant will be other cranial nerves or any lesion you found. You will carry on your examination, checking for the arms, checking for the legs, checking for the gait, or other relevant examination. All right. And the pure sensory cranial nerves are cranial nerve 1, that is olfactory, optic, and 8th nerve. And mixed cranial nerves are 5, 7, 9, and 10. So actually, just I want to tell you that you should know that these are the pure motor, pure sensory, and mixed cranial nerves. All right. Step by step, we will go towards the lower limb examination, towards the upper limb examination, towards the command of look at the patient and examine neurologically. All right. So what will happen here is that now comes the time duration for examination. The time duration is different for PACES, different for FCPS. I am not sure about what is in MD, but most probably it will be 4 to 5 minutes. So for PACES candidates, it is 6 minutes examination. You have 6 minutes with the patient, 4 minutes with the examiner. So it is only 4 minutes viva. So don't spend much time on books. Just study smart and just study what the examiner want from you. They don't want the long explanation of your condition or something like that. And for FCPS candidates, it is only 4 minutes. Just consider it 4 minutes, or you are lucky if you get 5 minutes. And one thing more I want to tell here is that in FCPS exam, immediately the bell will ring and you have to rush towards your next station. And during your movement, that you are shifting from one station to another, your time will be counted. That's why I was saying it is 4 minutes or 4 minutes 30 seconds. But in and same goes for PACES candidates, because what happens is that you have to go through the neurology station as well as cardiovascular station side by side without any gap. Either you will get neurology station first or you will get cardiovascular station first. And meanwhile, you will not have time. You will go inside the room, they will tell you the command, then you will come to know that okay, it is neurology short case. So be prepared for this thing. Now coming towards the exam scheme. For the PACES candidates, it is something good for them that their scheme has separate marks, their identifying physical sign has separate marks. So the examiner has to tell you what marks you got in physical examination, in your neurology short case, or any other short case, and what marks you got in your identifying physical sign. I just want to share here that, for example, if your identifying physical sign is a bit low, they will cut your marks in physical examination as well. But if your identifying physical sign is up to the mark, you can get full marks in your physical examination. And ultimately, you will get full marks in your clinical judgment and maintaining patient welfare. So what happens in lower limb examination scheme? Whether it is FCPS exam or it is MRCP PACES exam, Bell will ring. You will go inside the room. You will greet your examiner. After that, you will sanitize your hands. Must remember to sanitize your hands. Okay. And in case of PACES, meanwhile you sanitize, you look at the wall. There will be a paper hang over the wall on which the command or the scenario will be written. That, for example, this young man or this middle-aged man or this old man has presented with so symptoms. Whatever symptoms they have written. For example, they usually write the symptom that this patient is having difficulty in walking. Please examine the lower limbs. Okay, so read the scenario carefully. There might be a clue. After that, you will greet the patient. One thing more I want to tell here is that when you are sanitizing your hands and you are reading the scenario, in those 2 to 3 seconds, you should also examine the surroundings as well. For example, when you enter the room, you can observe that there is a wheelchair or there is a walking aid, walking stick, foot orthosis, or crutches. Okay, and you should tell this in your presentation of your short case. So after that, after sanitizing your hands, you will greet the patient. For example, if it is even if it is FCPS exam, it is MD exam, or it is PACES exam. I am talking about the center of Pakistan. Here you will introduce yourself in your local language. What happens is that outside, when even before the start of your PACES exam, the examiner panel will come and they will greet you. They will have a general introduction with you, and then they will tell you that you can proceed with the patient in your local language. This will give you quite much relief. Actually, doctors, what happened is that I am telling you my experience, because when I was appearing in my exam, there was nobody to tell me that what will happen on the exam day or what will I do, whether I will proceed in English or whether I will proceed in Urdu. Let me tell you one thing, that even on the day of exam, I was not sure that whether I will proceed in Urdu with the exam or what will happen. It was just at that moment when the examiners come inside the room, the examiner whole panel came and they introduced themselves, and then they told that okay doctors, you can proceed in your local language with the patient only. When it comes to the surrogate, you will have to take the history in English, you will have to do the communication in English. All right, so it is same for as for FCPS exam, that what you will say, you will say to the patient, अस्सलाम वालेकुम, मेरा नाम डॉक्टर मुबशरा है, और वट एवर, मेरा नाम डॉक्टर फायजा है, मेरा नाम डॉक्टर अली है, मैंने आपका मुआयना करना है, कहीं आपको दर्द हुई तो बताइएगा, मैं वहीं पे रुक जाऊंगी. Just 1 to 2 seconds. No need to exaggerate this sentence. No need to ask about the pain, and no need to take consent from the patient in the, for example, something कि मैं आपका मुआयना कर लूं. No, you will just say that मुझे आपका मुआयना करने को कहा गया है या मैंने आपका मुआयना करना है. आपको कहीं पे दर्द तो नहीं है. He will say दर्द है नहीं है. No need to say like that. You will say आपको कहीं पे दर्द हुई तो बताइएगा, मैं वहीं पे रुक जाऊंगी. All right. So after that, you will have a general look of the patient from the bed end. What you will look? You will look for visual aid. What visual aid? It is not simple glasses. Okay, it can be prism glasses. For example, prism glasses which patients wear for diplopia. You will look for hearing aid. Hearing aid can give you the clue that patient might be a case of Frederick ataxia. You will look for extensor posture response. For example, the posture which most of the stroke patients have. You can also look for double lumen catheter in the neck. It will give you a clue that this patient might be a case of myasthenia gravis. It might be a case of GB syndrome. It might be a case of acute flare of multiple sclerosis. Okay, so have a good observation, good general look of the patient. Instead of when in the last seconds you look these things, then you will puzzle and you cannot correlate your symptoms, or you will just get panic that I look at the neck at this time of my examination. Okay, so in the start, initial 10 to 20 seconds are very important. And these can only be possible if your nerves are calm. Just be confident. Nothing will happen, because all of us have done the training. All of us are almost on the same page. If you have done work hard, if you have done a good training, then Allah Almighty will also help you in your exam. All right. You can also look at the ptosis. For example, it can be unilateral ptosis, it can be bilateral ptosis. If it is bilateral ptosis, you can think of that this case might be a case of myasthenia gravis. It can be a case of myotonic dystrophy. If it is unilateral ptosis, then still you can think of that it might be a case of, for example, Weber syndrome, or it might be a case of diabetes mellitus, because diabetes also affect the third nerve. All right, and there are multiple other causes. You can also have a general look at whether this patient has facial palsy, although you will also examine it at the end, but just as a general look. You will also look for, okay, you have looked for wheelchair, walking aid, walking stick, okay, and then come towards the exposure. I would say don't spend too much time. It's just 10 to 20 seconds. If you will go in the ward, you practice with the patients, you can do this initially in the 5 to 10 seconds. All right. So after that, you will have the proper exposure of the patient. It is very good thing for PACES candidates that the patient is mostly always exposed. You don't need to do the exposure yourself. But what happened in FCPS exam? The FCPS candidates have to do the exposure because sometimes they test the patient just to check whether the candidate will make proper exposure or not. Dr. Faiza, my voice is clear?
Yes, Dr. Mubashir.
Okay. So for lower limb examination, your exposure must be till thigh. I would say it should be towards upper thigh. At least more than half of the thigh should be exposed. Because what happens is that sometimes it can be a case of myopathy. You can miss the muscle biopsy scar which can be present in the upper thigh, just below the inguinal ligament. Because I have seen such patients, especially who are appearing in Rawalpindi Center, they have such patients who have muscle biopsy scar high above the knee, high above in the thigh, in the upper one third part of the thigh. Okay, so your exposure is too important. Okay, after that, as we all know, it is inspection. After that, during inspection, what you will look for? Now, you will look for pes cavus. Now, whenever you will look, okay, this is pes cavus, you can become confident that what can be the causes. Pes cavus can come in Friedreich ataxia. It can come in Charcot-Marie tooth disease. Okay, and let me tell you one thing, that these patients are also present in Pakistan. Uh, we normally can't see them in the ward quite casually, but still they are present. Okay, and these PACES pool is a separate pool of patients. It is not like FCPS exam, no? That they will bring the patients from the ward, the house officer or the PGRs will decide which patient will go and all about that. But in PACES, they have separate pool of patients. Most of the time, they are not admitted patients. Okay, so what happens is that you will look for press cavus, you will look for foot drop, you can look for scars, muscle biopsy scar, which I already told, and tendon release scar, although these are very rare. Okay, then you will look for fasciculations. In fasciculations, what you will look? You can look for spontaneous fasciculation as well as induced. Because what happens is that sometimes, let me tell you one thing, that the PACES candidates, the PACES examiners, they will be on you. You will feel during your exam that they are just coming towards your right side or towards your left side. So they have a very keen look on your face as well as your hands and what examination you are doing now. So what happen is that they will see that whether have you checked for spontaneous fasciculations, or you are just coming and doing your steps and just tap on the thigh and not look for the induced fasciculation and just jump towards the next step. Just relax. 1 to 2 seconds will not cost you much. Okay. So you will first look for spontaneous fasciculation almost 1 to 2 seconds in both thighs. Okay. Then you will look for induced fasciculation. What you will do, you will tap on the thigh, on the muscle bulk part now with your two fingers. Okay. Two fingers you will tap and then you will look for induced fasciculation. After that, you will check for the bulk. Compare both, but no need for measuring tape as it happens in FCPS exam, because it is quite controversial. Some say that use measuring tape or what, but in PACES no such need. And in PACES you don't have to bring any instrument except the stethoscope. They will provide you each and everything When you enter the exam, near your examination couch, near the patient, there will be a table, and everything will be placed over there in quite much sequence, and even the examiners will help you. For example, you don't have to look for any thing. You don't have to look for a hammer. Okay, where is the hammer? Even some examiners are so good that they will bring the hammer and give it in your hand. Okay, so you will check for tone. Okay, there are different methods to check for the tone. What I would suggest is that there is a method. I cannot demonstrate here online, but I can tell you, and I hope many of you doctors will understand what I am trying to say. You will put your both hands under the, just rest the knee of a patient. Okay, your fingers will be down in the knee, and you will just give a quick pull, and you can assess the tone. If you have practiced this method of examining the tone, this is a very good method, because immediately you can assess that it is spastic or it is flaccid. If it is spastic, what will happen? The foot will hang on the in the air, and then it will come down. And if it is flaccid, it will immediately drop to the examination couch. I hope you are understanding. Okay. This is one method of checking the tone, but it is not it is not complete. The tone assessment is not complete yet. You have to check the tone in proximal muscle as well as in the distal. You will raise the leg of the patient, and you will assess the tone at the ankle joint, that is the foot tone, that whether the tone is decreased at the distal extremity or it is in the proximal extremity. Okay, proximal, you will also look for like, you will hold the leg of the patient, and you will do the passive movement at the knee joint. You will close it, and then you will check the movement around the hip joint as well. So basically, you will assess the tone: one, the flicking movement; another at the ankle joint; another at the knee joint; and then the rotatory movement around the hip joint. After that comes the power. Power, what you will say to the patient? Okay, जैसे आपने उर्दू में कमांड देनी है, यू विल से कि आप अपनी दाएं टांग मेरे हाथ पे लगाएं। आपका हाथ ऊपर होगा, पेशेंट आपके हाथ को टच कर सकेगा, वेल एंड गुड। आपको असेस हो जाएगा कि एटलीस्ट द पावर इज 3। इफ ही कैन नॉट, यू कैन जस्ट से हिम कि आप अपनी टांग जो है वो साइड बाय साइड मूव करें। जस्ट रोल योर लेग साइड बाय साइड। अगर वो रोल कर सकता है, ओके फाइन, इट इज 2। इफ स्टिल वो ये रोल भी नहीं कर सकता, तो आपसे कहेंगे कि अपने पाँव के पंजे हिलाएं। अगर वो पाँव के पंजे हिला सकता है, आई मीन यू कैन से इट इज फ्लिकरिंग मूवमेंट ऑफ द टोज ऑफ द फुट, देन इट इज 1 पावर। If still there is no flickering movement of the toes, then you will say that power is 0/5. All right?
Slow.
What, Dr. Faiza?
You're right.
Is it okay now?
No.
It is still low.
Yes.
What about now? I don't know what is the problem undergoing, but I have changed my headphone as well. Earphones as well, but is it okay now?
Yes, it is audible, but a little bit low. Okay, we can proceed with it.
All right. If it gets more low, then
yes. Now it's fine. Now it's fine.
All right. Okay. So, have you understood what I want to tell you about the power?
Yes.
Okay. This was one method of checking the power. Okay. Then you can check the power in your distal extremity. For example, what you will say, you can say that जैसे आप कहेंगे पेशेंट को कि अपना just wait a second. I have upgraded my Zoom, but still it is showing me that remaining time is 10 minutes. I think you can rejoin the meeting by the same ID. Okay. So, when you are assessing the power in the foot, then what will you say? कि आप अपने पाँव को अपनी तरफ मोड़ें। पेशेंट को पहले एक्टिव मूवमेंट करने दें, then you will do against resistance. Okay, then you can have a good assessment that whether he can move his foot properly or whether the power in the foot is good. Okay, and in the same way you can check the power in the I mean in the legs below the knee and above the knee. जैसे आप उसकी चेक करेंगे अडक्टर मसल की पावर और abductor muscles की पावर इन द थाई. You will see that बाहर की तरफ जोर लगाएं, अंदर की तरफ जोर लगाएं. I hope you people are getting. After that you will move toward the reflexes. You can check the reflexes in the ankle reflex and you will also check in the knee. Okay, and if the reflexes are exaggerated, don't proceed further before checking the clonus. For checking the clonus, you will make the 90 angle, okay, 90 angle of the leg at the knee joint, and then you will check the clonus and you will be able to elicit if the reflexes are exaggerated. Okay, now coming toward the planters. For FCPS candidates, you should have a key in your examination kit. You will check the planters with the key. But for PACES candidates, there is an orange stick. It is basically called orange stick, but it is not necessary that it is orange in the exam. If you don't find it, don't panic. The examiner will guide you that what you need. I want to check the planters. They will hand over you the orange stick. After that, you will check the coordination. Coordination, that is heel shin test. If the power is 0 by 5 or 1 by 5, low power, you cannot check. You will proceed towards your next step. Otherwise, you have to check in the both legs. After that, you will check for sensations. By sensations, I mean all four modalities. Pinprick, sharp touch, soft touch with cotton, proprioception, joint position sense, vibration, and vibration is done by tuning fork. All right. After that, you will check the gait of the patient. The gait can be spastic, it can be seizuring, it can be high steppage, wide based, hemiplegic, or even it can be magnetic gait. Romberg test, you can check if there is loss of dorsal column. For example, in proprioception or vibration, you assess that there is loss of joint position sense or loss of vibration, then you will check for Romberg test. But make sure that the patient is standing near the couch and there is a proper support available so that the patient does not fall. All right, Dr. Faiza, my voice is okay?
Yes, yes.
Okay. So after that, coming towards the relevant of lower limb examination. Let me tell you one thing, that this gait part is included in your lower limb scale, because this thing most of the FCPS examiners, they highly dislike that gait is not your relevant. It is the part of your lower limb. For example, if the patient has good power, you should proceed towards the gait instead of jumping towards upper limb examination. All right. So the relevant of lower limb examination, it is most important is upper limb examination. In upper limb examination, you will just do pronator drift or pronator catch. You will just give the command to the patient कि आप अपने बाजू इस तरह करें. This is the best command which I experienced, because instead of telling them something, just show them how to do. And what your posture should be during checking pronator drift, your palms should be towards the I mean your palms should be above, your palms should be towards the ceiling in this way, and then ask the patient to please close your eyes, and just in 1 to 2 seconds you can assess that yes, this patient has positive pronator drift. If it is a case of hemiplegia, it can be unilateral, or if it is a case of quadriparesis, it can be bilateral. If it is quadriplegia, patient will not be able to do the pronator drift. All right, and the most important thing you can do in low upper limb examination is cerebellar sign, because sometimes what happens, even if the cerebellum of the patient is involved, you cannot check or you cannot assess from the heel shin test. The best thing is finger nose test. Even more than this diadochokinesia, finger nose test is more sensitive. And you can check for Hoffman sign in the upper limb. I hope you people know what is Hoffman sign. For example, if you assess that this patient has hemiplegia or hemiparesis, it is a case of stroke, then you can check this on the side of the ligand. For example, if it is right-sided hemiparesis, what you will do, you will take the right hand of that patient and just do a flicking movement on the middle finger of the patient right hand. I mean that hand which has the weakness. And if you perform the flicking movement of that finger just over the nail of that patient in a quick way, you can assess that the patient has movement of index finger towards the thumb. That is flexion of thumb as well as flexion of index finger. This is positive Hoffman sign. I would suggest that go to your ward. Whenever you go to your ward during examination, the stroke patients will commonly found. I will not say that it is not always present, but when it is present, it is a confirmatory sign for upper motor neuron lesion. All right. So what happens is that after they moving towards this, the most important part is cranial nerve examination. In cranial nerve examination, it varies according to your case. Okay, what cranial nerve you should check in your relevant examination, it will be extraocular muscle. That is the H movement we perform in our examination. Or you can check for nystagmus if it is cerebellar involvement. Or you can check for pupils. For example, if it is if it is unilateral ptosis, you can check for the size of pupil. You can check for the whether the pupil is fixed dilated or something like that. And you can check for internuclear ophthalmoplegia. You can check for facial nerve palsy. All right. And if I have put this pulse and precordium in the relevant examination of lower limb because if it is your case of hemiplegia, you should check the pulse for any irregular rhythm. You should check the precordium for any murmur. All right. So all of this basically varies according to your case. Now coming toward your task or what the examiner wants from you. And mostly the examiner questions, especially in case of FCPS exam. I'm emphasizing because in case of PACES exam, they will not ask such questions from you. They just only expect that whether the candidate is able to tell this answer in their diagnosis. Okay, because there they have to ask what is your diagnosis, what are your findings, and what is your investigation, and how will you manage this case. But in case of FCPS exam, they can ask you anything. They can ask you what is the lesion, where is the lesion, why is the lesion. Most of the cases, for example, if it is a case of stroke, they will ask you that what is the lesion. We will come towards this point. What is the lesion? What they demand? Mostly the lesion is upper motor neuron lesion or it is lower motor neuron lesion. How will you check it? First, you need to know what is upper motor neuron and what is lower motor neuron. Mostly what happens is that in upper motor neuron, basically these start from the primary motor cortex and end on the anterior horn cell of the spinal cord. And the lower motor neuron, they start from anterior horn cell of spinal cord and go towards the target organ. For example, I hope you people are able to see this picture. This is the brain, this is the primary motor cortex. From this primary motor cortex, the upper motor neuron will start and then they will descend through the brainstem into the spinal cord towards the anterior horn cell. If there is any lesion between this level, this is the lesion of upper motor neuron. After this, there is lower motor neuron. I think this class is going to end. I don't know why I have upgraded my Zoom, but I think you people will be able to again join this class by clicking on the same link. All right. Let me check the chat. Okay, so we were here. I told you about the course of upper motor neuron, the course of lower motor neuron, and this was about the course of lower motor neuron when they start from the anterior horn cell of spinal cord towards their target organ. And again, the same thing, and this thing I was telling to the FCPS candidates that they should know about this diagram because the examiner may ask you in your long case that please draw the corticospinal tract or please draw the course of upper motor neuron. All right. So coming towards this point, the examiner will ask you where is the lesion. Especially they will ask this point in your case of hemiplegia or a case of stroke. they will ask you where is the lesion, and you should be able to identify where is the lesion if you just remain focused in the next couple of minutes. The lesion can be in the cortex, it can be in the internal capsule, it can be in corona radiata, it can be in the brain stem. How will you localize? I will tell you in the couple of minutes. Okay. One thing here I want to mention before we go towards the lesion localization. For example, if you get the command of lower limb examination, uh, just think that it might be a case of hemiplegia, monoplegia, paraplegia, or quadriplegia. I'm saying plegia in case if it is 0 by 5 power. Even if it is 1 or more than 1, then it is paresis. Alright, so always there will be these four things which you can expect during your lower limb examination. And what type of things you can expect in upper motor neuron type of lesion? It can be hypertonia, increased tone, exaggerated reflexes, hyperreflexia. It can be clonus in the lower limb or Hoffman sign positive in the upper limb. It can be extensor plant, but I am not saying it can be, it would be, it must be. Extensor plantar response, either the plantars will be upgoing or they may be mute. There will be pyramidal type of weakness. What is pyramidal type of weakness? It is basically when extensors are weaker than flexors in upper limb and flexors are weaker than extensors in the lower limb. Okay. And it can be like, it can behave like a lower motor neuron lesion that is placid in the initial stages. For example, if it is the patient is in spinal shock in case of stroke, but you can't find wasting or fasciculations. Wasting can be there if it is a long standing disease, but mostly it is not the feature of upper motor neuron lesion. So if it is a case of stroke, in lower limb examination you will find unilateral leg weakness. Okay. And here the lesion localization will come, that lesion will be at the level of brainstem or it will be at above the level of brainstem. If it is at the level of brainstem, it is good that you will say just a broad term that is brainstem, but it is more good if you can localize it further, that whether the lesion is in midbrain, pons, or medulla, by further examining your patient. All right. And if it is above the level of brainstem, then again there are three areas where the lesion can be there. For example, it can be in the cortex, it can be in the internal capsule or corona radiata. If it is in the brainstem, for example, if you localize, how you will localize? You just elicited that the patient has right-sided hemiplegia or right-sided hemiparesis, for example. Then coming towards the face, when you are coming towards the cranial nerve in your relevant examination, then you can assess that yes, this patient has third nerve palsy and it is on the same side, that the same side of the weakness. And this you can assess, for example, when you were examining in the initial 5 to 10 seconds at the foot end, that this patient has unilateral ptosis. And then you can also look at the lower limb of the patient, that जैसे उसका पाँव एक साइड पे झुका हुआ है, जैसे हमें स्ट्रोक के पेशेंट्स में मोस्टली अंदाजा हो जाता है. So if it is ipsilateral, that is same-sided third nerve palsy with ipsilateral hemiplegia, it is a case of Weber syndrome, and you can confidently say that the lesion lies in the midbrain at the level of brainstem. And if the lesion lies at the level of pons, what clinical sign you will assess in your cranial nerve? You can assess sixth nerve palsy, the opposite side of weakness, opposite side of sixth nerve palsy. The patient will not be able to abduct his eye on the opposite side of the weakness. For example, if it is right-sided hemiplegia in your clinical examination of lower limb and upper limb, and the patient has left abducent nerve palsy, that the patient cannot abduct his eye of left eye, then it might be Millard-Gubler syndrome. All right. And in Millard-Gubler syndrome, seventh nerve is also involved. After that, the lesion can be in the medulla. In medulla, it can be medial or it can be lateral. It will be medial medullary syndrome or lateral medullary syndrome. Medial medullary syndrome, your hypoglossal nerve will be involved. I think we all know the mnemonic or the famous term, that is tongue never lies. Same side hypoglossal nerve, same side weakness. All right. It is basically that if it is an old stroke, then you can assess that there is atrophy of tongue on that side, or if it is a new stroke, then when you give the command to the patient that can you please stick your tongue out, then the tongue will be deviated towards one side. Or when you assess the motor component, again uh, it will be uh, low power. Okay, and lateral medullary syndrome, the famous syndrome, pica syndrome, Wallenberg syndrome. All right, so what happens is that in case you can get the lateral medullary syndrome when the command is examine the cranial nerve of this patient. That is a separate thing. Here I am talking about hemiplegia. All right, so if the lesion is above the level of brainstem, either it is cortex, internal capsule, corona radiata. So how you will assess? You can assess it in the, for example, signs of cortical lesion. The most important sign of cortical lesion, which I haven't mentioned here, is speech. If the patient has aphasia, then you can say confidently that the lesion lies in the cortex, in the cerebral cortex. Other points which you can check is stereognosis, graphesthesia, 2-point discrimination. But you cannot assess because you don't have much time in your short case. So you can assess this in your long case, especially in case of FCPS. Stereognosis, graphesthesia, or 2-point discrimination, any of such sign. Okay. And after that, for example, if the lesion lies in the internal capsule, you will find very dense hemiplegia. What does it mean? That patient has equal weakness in both upper limb as well as lower limb. For example, it will be 0 by 5 power in lower limb as well as in the upper limb. Then you can confidently say that the lesion lies in the internal capsule. And this is quite rare that the lesion lies in the corona radiata. It is actually dissociated weakness. It can be only monoplegia or something like that. One thing here again I want to mention is that, for example, if the arms are weaker than the legs, or the opposite, that the legs are weaker than the arm, then what examiner wants to ask from you is that whether his anterior cerebral artery is involved or middle cerebral artery is involved. For example, we know that middle cerebral artery is involved, then then the weakness is more prominent in the arms. If it is anterior cerebral artery, weakness is more prominent in the legs. Okay. And the famous saying of mostly when we are preparing for FCPS exam, we know that lesion lies because of the occlusion of lenticulostriate branch of middle cerebral artery and everything. And another thing is that I want that whatever clinical exam you are appearing, you should tell a comprehensive diagnosis. You shouldn't say only yes, this is a case of stroke. Everyone can see this is a case of stroke. Even the house officer can also say yes, it is stroke. So what is the difference between a house officer and a good resident or a registrar, specialist registrar, or a nearby consultant? That you will tell a comprehensive diagnosis. It is an upper motor neuron type of lesion involving the lenticulostriate branch of middle cerebral artery. Patient has presented with right-sided hemiparesis along with facial palsy on the left side, or whatever your diagnosis is. You should give a full comprehensive diagnosis. All right. Dr. Faiza, are you there?
Yes, yes.
And my voice? What about my?
Your screen.
It's okay.
Yes, yes.
Okay. So now coming towards the other thing, that apart from hemiplegia, what you can expect in your lower limb examination, it can be a case of paraplegia. Since we are talking about upper motor neuron type of lesion, so that's why I will say what you can expect in spastic paraplegia. This is also a very common case in your exam, that you get a case of spastic paraplegia. Now these are the common causes of spastic paraplegia, but you should be able to comment further when you will assess further. Just give me a second. Um, Okay, the common causes we all know. Whenever it is spastic paraplegia, it can be multiple sclerosis, it can be motor neuron disease, it is spastic paraplegia, Friedreich ataxia, subacute combined degeneration, multiple causes. But you shouldn't tell all these causes because examiners don't like that you have ratified these things or something like that. You should have a good knowledge now that why you are saying this and why you are saying that. Just give me 1 minute because okay. So one thing here I want to ask is that in case if it is a spastic paraplegia. And you assess the patient, he has spastic paraplegia, all the signs of upper motor neuron lesion, that is hypertonia, hyperreflexia, clonus, upgoing plantars, and um then you will check the sensations. For example, the sensations come out to be normal. I mean, they are normal in terms of all four modalities. Then what things or what differential you will think? Anybody can write in the chat box. Actually, I am speaking and my throat is now hurting. I was not expecting this because people are saying that my voice is low and I am actually shouting, but I don't know what happened.
Which sides? And there is no sensory involvement and no other involvement like cerebellar involvement, then the differentials would be like parasagittal meningioma or MND, or or it could be like bilateral strokes, and other than that it could be what else?
Very good, Dr. Faiza. One thing, parasagittal meningioma, put this in the last. Okay, rest it is good.
Okay.
Yes, most important is motor neuron disease. Spastic
Yes, motor
paraplegia
neuron.
with normal sensations. First differential you should say motor neuron disease. Even it can be multiple sclerosis, but still motor neuron disease comes in the top because what happens in multiple sclerosis, mostly dorsal column is involved, cerebellum is involved. Okay, hereditary spastic paraplegia, your second differential, and then you can say any of these because all of these three are very rare. Okay, motor neuron disease, hereditary spastic paraplegia. Even let me tell you, if PACES examiners will be more than happy if you tell the first two differential: motor neuron disease, hereditary spastic paraplegia. That's all. Cerebral palsy, syringomyelia, parasagittal meningioma, yes, they are the theoretical causes of upper motor neuron type of weakness with normal sensations, but normally or commonly, upper two cases are mostly seen. Okay, okay. Then next thing, for example, there is spastic paraplegia, and in sensations, pinprick sensation, you get a sharp sensory level. Now think what could be the cause.
If we get a sharp sensory level, then it could be transverse myelitis or first presentation of multiple sclerosis or spinal cord compression. If there
Hmm.
is involvement of the bladder and bowel involvement also, then it would be spinal cord. Actually, we can divide it broadly into compressive causes and non-compressive causes. Like
Yes.
spinal cord compression, spinal causes like non-compressive. It could include imaginative MS and transverse myelitis, or it could be subacute command degeneration as well, and even MND as well, or having spastic paraplegia, depending upon other findings of the
Okay,
examination.
very good, Dr. Faiza. Don't keep M&D. Whenever there is sensory loss, M&D comes even comes zero. Okay, so very
Okay,
good.
okay. Oh, yes.
Okay, so very good. It is compressive or non-compressive. It is either spine. Whatever always we think about, we get sharp sensory level. It is spinal cord compression. All right, spinal cord compression. You remember the T common T tumor, trauma, TB, abscess, hematoma, the theoretical causes which we have learned during our training or during our FCPS course. Okay, but mostly it is spinal cord compression, and it there can be any cause. And after that, the non-compressive lesion, mostly when the patient has transverse myelitis. And transverse myelitis itself, it is a broad topic. There can be multiple causes. It can be viral infection, bacterial infection. Patient can have demyelinating disease like multiple sclerosis, or even it can be a presentation of vasculitis. For example, the patient of SLE or patient of connective tissue disorder, which you see with stroke. Sorry, not stroke, with paraplegia or paraparesis. The underlying cause is transverse myelitis, non-compressive lesion of the spinal cord. Okay.
Yes, okay.
Actually, as I was not shifting the slides again, I was just taking from my mobile so that you people will also get involved. Okay, now next question. If it is a spastic paraplegia and dorsal column is involved, first there was no sensory loss, then there was sharp sensory loss, sharp level, and now no sharp level, no sensations loss in term of pinprick or soft touch, but the dorsal column is involved, like proprioception or joint position sense. Now think of the
Yes.
causes.
Then most common cause is multiple sclerosis.
Hmm?
Other than that, it could be subacute combined degeneration.
Hmm?
And other than that, it could be Frederick ataxia.
Very good. Okay, so remember the mnemonic C mast. Okay, someone is suggesting me to drink water in between. Yes, I'm drinking. Thank you. Okay, so C mast. But here again, instead of jumping towards cervical myelopathy, first you will say it is multiple sclerosis, Frederick ataxia, subacute combined degeneration, then cervical myelopathy, then tavoparesis. And one thing also I want to share here is that cervical myelopathy cases are also there. These patients are mostly presented with quadripresis or quadriplegia. And one sign you can get during your first initial 10 seconds of examination is that mostly they have cervical collar. So I think I didn't mention the cervical collar in your initial inspection. If patient has cervical collar, think of cervical myelopathy. All right. Wait. Uh, okay, so if it is spastic paraplegia, dorsal column is involved, cerebellum is also involved. Now think of the causes.
Now it would be Frederick ataxia at number one if the patient is young, or if the patient is older than multiple sclerosis.
Hmm.
And other than that,
But only two causes. Okay, multiple
yes,
sclerosis, Frederick ataxia. Multiple sclerosis can also occur in young patients. Okay, both of
yes,
these
yes.
patients will be young. Both of these patients may be old. But if it is young, then only two causes, no? Upper motor neuron, dorsal column, cerebellum. All these three things are involved. Keep the differential multiple sclerosis, Frederick ataxia. Just close your eyes and think about only these two causes. If the patient has hearing aid, then Frederick ataxia will be on the top. If the patient has pacemaker, for example, he is fully exposed, he has removed his shirt, and you can see the pacemaker scar, or you can see some bulge on his chest on the precordium just below the clavicle, then think that this is pacemaker in situ. This might be a case of Frederick ataxia. All right.
Okay.
So if it is, for example, upper motor neuron, dorsal column, cerebellum, along with peripheral neuropathy, that sensory loss as well, then what you will be your provisional diagnosis?
Upper motor neuron and dorsal column and cerebellum along with peripheral neuropathy.
Yes,
Evaporis, no. Uh,
Frederick ataxia.
okay.
Because Frederick ataxia can come with peripheral neuropathy as well.
Yes, okay, all right.
Okay, so this was a brief discussion about the level of lesion, I mean the type of lesion, upper motor neuron. Okay, when we were examining the lower limb. Now coming toward the lower motor neuron, and still we are in the lower limb. Okay, people. I hope you people are getting. There are a lot of messages in the chat box, but I couldn't read them meanwhile. So what is the level of lesion if it is a lower motor neuron? Immediately when you were checking the tone of the patient, before starting the tone even, when you were just inspecting the patient, there was wasting, there was spontaneous fasciculations as well as induced fasciculation. Just start thinking, just start brainstorming that it might be a case of lower motor neuron in the lower limb. Then where can be the lesion? It can be in the anterior horn cell of spinal cord. For example, it can be motor neuron disease, amyotrophic lateral sclerosis, even some rare cases spinal muscular atrophy or poliomyelitis. But poliomyelitis, you will have a clear description that one leg will be weaker than the other, bulk will be not comparable on both sides. Another level is nerve roots, GB syndrome or radiculopathy. Plexus, lumbar plexus, cervical plexus, very rare to come in exam. Peripheral nerves. Now this is an important case which can come in the exam. GBS, CIDP or vasculitis, mostly GBS and CIDP. Here the lesion can be in the peripheral nerves. So you see, in the GBS, the patient can have the level of lesion can be in the nerve roots. The level of lesion can be at the level of peripheral nerve, because we often ask the patient, or patient of GBS often complain that they have backache. This backache was because of involvement of nerve root. And then the level of lesion can be at the level of it is polyneuropathy, most common case peripheral neuropathy, which often encounter in the exam, sensory motor mixed sensory motor. Okay, you people all know the causes of sensory neuropathy, motor neuropathy, or mixed sensory motor neuropathy, mostly diabetes, alcohol, and blah blah. Okay, features of lower motor neuron. Again, I was telling wasting fasciculation, low tone, even the tone can be normal. Then patient can have hyporeflexia, or patient can have absent reflexes. Here, one thing I want to mention is that before telling the examiner that the reflexes are diminished or the reflexes are absent, you must do the maneuver. What maneuver you do? You just ask the patient clench your teeth, or you will ask the patient to do just close your fist tightly. All right, and then you will do the reflexes, and then you can say confidently, yes, the reflexes are absent or the reflexes are diminished. And after that, planters are downgoing in case of lower motor neuron lesion. Okay, again, so the same thing. When you are examining the lower limb and you assess that this patient has flaccid type of weakness, it can be in the form of monoparesis, it can be paraparesis, it can be quadriparesis. If it is monoparesis, it can be mononeuropathy or radiculopathy or plexopathy. If it is mononeuropathy, for example, you can get a case of common peroneal nerve palsy. Mostly it can come in PACES exam. They have such type of patients. Okay, then you can also check for radiculopathy. These patients can also come in FCPS exam. If you get a flaccid type of weakness and it is paraparesis, both legs are involved, the case might be either myopathy or polyneuropathy. Because if it is no, neuromuscular junction disorder, myasthenia gravis, for example, mostly the command won't be lower limb examination. And if it is quadriparesis, again, a myopathy, polyneuropathy, polyradiculopathy, or neuromuscular junction disorder. I will discuss the detail further in a couple of minutes. Okay, now coming towards commands of upper limb examination. For example, you enter the room and the examiner tell you examine the upper limb of this patient. Quite unusual command. Most of our candidates do not like this command. But think, they do not want you to assess for upper motor neuron type of lesion from upper limb examination. What will happen mostly? If it is a logical exam or if it is a lenient examiner, they will give you a cerebellar lesion if the command is upper limb. So instead of giving you the command of lower limb and you just complete that and Hilshin test you couldn't assess, that's why they have given you the command of upper limb. So it might be a case of cerebellar lesion. It might be a case of myotonic dystrophy. How you can assess myotonic dystrophy from upper limb examination? You will just shake hand with the examiner and you can assess fist myotonia. You can assess that the patient cannot leave your hand. The patient, you can assess percussion myotonia. What is percussion myotonia? You will just after this fist test, you can just tap on the I think it is thenar muscle or hypothenar muscle. Yes, it is thenar. No, it is hypothenar muscle. You will tap with the hammer on the hypothenar muscle and there will be flexion of the thumb. This is called as percussion myotonia. And also you can assess for, you can expect that it might be a case of proximal myopathy. That's why the command is upper limb examination. It might be a case of polyneuropathy. Okay, this radial nerve, ulnar nerve, median nerve palsy, this is commonly present in the PACES exam. Especially in the Rawalpindi Center, they have such cases who have ulnar nerve palsy, radial nerve palsy, or median nerve palsy. Okay, their examination, their steps are a bit different. You should read them from, I would say, Gautam Mehta. Examination steps are same, just a few points it has written. Okay. If the command is look at the face and examine neurologically, what what might you think now? There is something in the face that might be present. The candidates will be able to assess it, pick it, do the examination of face, and after that come towards the relevant examination. Mostly the case will be myasthenia gravis or myotonic dystrophy or Parkinson disease, or it might be cranial nerve palsy, which can be assessed just by looking at the patient on his face. If it is a case of myasthenia gravis, you can look for ptosis. There will be frowning of the forehead. If it is myotonic dystrophy, again, patient will may have ptosis. Patient will have long haggard face. There will be frontal balding. There can be frowning of the forehead. If it is a case of Parkinson disease, patient will have expressionless face. There will be infrequent blinking. There may be drooling of saliva. And the cranial nerve palsies might be assessed by just looking at the face. You can assess that patient has ptosis. It can be complete ptosis, it can be partial ptosis. And once you open the eye or the patient will open, you can see that the patient has down and out eye. In case of third nerve palsy, it can be fixed dilated pupil. If the pupil is involved or pupil is not involved, we all know about that. That is a further detail. I'm not going in the detail of that examination. Again, you can assess that just by looking at the face, you can see patient has facial palsy. You will start examining for facial now, and then you will go towards the relevant examination. Your relevant examination is quite broad. The facial nerve examination is very important, especially for PACES candidates. They will say just look at the face, examine neurologically. You will looking at the face, you will assess that patient has facial deviation. You will check the facial nerve, then you will look for, before moving towards the arms or legs, you will check the cranial nerves, but you will check the relevant cranial nerves only. For example, you can say it is an old age patient and he has facial nerve palsy, then it might be a case of stroke, or it might be the case of just Bell's palsy, or it might be the case of cerebellopontine angle tumor. So before moving towards the arms and then coming back to the face again, it is good that you will check the other cranial nerves, that is 5, trigeminal nerve, 9 and 10, which are involved in CP angle tumor. Alright, so in this way, you can do your relevant examination of facial nerve. Then you can come towards the upper limb. You will check for pronator drift or pronator catch. You can assess the uh, patient for stroke. Patient can have Millard-Gubler syndrome. Patient can have involvement of sixth nerve. One thing I think I forgot, along with five nerve, you will also check for sixth nerve. Okay, because sixth nerve can be there along with seventh nerve, and the case might be Millard-Gubler syndrome. So in this way, you will do a slick examination. Okay, this thing is very important for PACES candidates. This is also very important for FCPS candidates. Before presenting your case towards the examiner or before start of Viva, immediately when the bell will ring, you will just turn towards your examiner, and even before sitting, you will say to your examiner, in order to complete my examination, I would like to perform a complete neurological examination including upper limb. For example, you are doing lower limb, huh? Then you will say upper limb, cranial nerves, gait in case if you haven't checked, fundoscopy, if it is relevant, mini mental state examination if it is relevant. For example, in which cases mini mental state examination will be relevant? If it is a case of Parkinson disease, okay, you will assess for mini mental state examination for Parkinson plus syndrome. You can say I would like to check for pulse precordium if you haven't checked and it is a case of stroke. Only in stroke it is relevant now. In not, for example, you get a case of multiple sclerosis and you are telling I will check for mini mental state examination, pulse precordium. Examiner will just look at your face and say why. So always do tell these things according to your case. Okay, you can say I would like to check the postural drop of this patient. For example, if it is a case of Parkinson disease, only then it is relevant to check for Parkinson plus syndrome. You will say I will go for urine dipstick for glycosuria or proteinuria. For example, when you were checking for pulse and you examined the finger prick marks and it was a case of stroke, then it will leave a good impression on the examiner. So always tell this thing relevant to your case. Okay, so key Dr. Faiza, my voice is clear?
Yes.
Okay. So smart work, no hard work. Although I will say that we don't get satisfied if we don't do the hard work, because we always say that just burn your boards and do everything in this 1 to 2 months and just pass your exam so that we can get free. Okay. But one thing is that many people do smart work and they get passed with very good color, with very good marks, or very in a very nice way. So smart work, smart study, this will be only possible if you know your exam, you prepare according to your exam. Now see, don't no need to open the CMDT for FCPS. In case if you are appearing in clinical exam, no need to open the Gautam Mehta Rider Mir, and you are just reading the scenarios and keep on studying the station 1 all the scenarios, station 3 all the scenarios. What you will get, you will only get all those things which you have already learned. For example, the examiner will ask not from you what is written in that book or on that page or whatever. So he will only ask what are your positive findings, what is your in the sorry provisional diagnosis, your differential, your investigation, your treatment plan. Okay, so try to be confident, because what they want is a confident doctor. What they want is a confident registrar, the patient, the doctor who does not miss uh, or the doctor who does not do blunder, all right, or does not miss the common diagnosis. And I would say please try to be simple in your exam. Just try to focus on the common things first. Okay. And all the examiners, mostly the examiners, they don't read the books now. You know, if even they are working in teaching hospitals, still they don't touch the books as much as we do, because they don't have time, they don't consider it important. Now they will just sit with their colleagues and they will just scroll their mobile and they will see okay what's new thing are coming, and most of the time even they don't know about them even. And for PACES candidates, these new updates or new drugs or new treatment is not needed. New advanced treatment is needed in FCPS exam. Okay. So another important thing is try to be slick, fluent examination. You don't have to think for your examination step that okay now I have done plantar, now whether I should go for heel chin or I should go for sensation. For this thing, I would say that in case if you don't have the access to the patient, you can practice the examination steps at home. You can practice with the pillow. You can practice with your kids, with your spouse, your brother and sisters. Okay. So this thing. And also I would say avoid unnecessary touching the patient. Maintain patient welfare. Do not cause pain to the patient. Your case presentation should be fluent. You should tell the positive findings first and important negatives in the end. For example, just imagine you are not in the hospital, okay? You are just getting that, okay, I'm not seeing the patient, what will happen in the exam? No need to worry about it. You have seen the patients, you all have seen. Just imagine it is a case of multiple sclerosis. He has spastic paraplegia, okay, his dorsal column is involved, okay, he has sharp sensory level. Just think, yes, these four positive findings or three positive findings, how will I present? Just present in front of the mirror, just present in empty room, or just present in front of your spouse, in front of your kids. You will tell only specific investigations mainly and treatment point wise. All right, this is the thing uh, which is the key to success. Basically, I would say instead of telling I would go for MRI brain, I would go for nerve conduction study. See, so if any one of you have any question, you can ask. You can unmute yourself or you can write in the chat box. If there is no question, I think now I have given the option that you people can unmute yourself on your own. Pronator drift. Okay, pronator drift is How you can check the pronator drift? If you have done the lower limb examination and the relevant, you will do the pronator drift in the arm. How you will do? You will just say to the patient that, can you do this? Can you please do this? Or if you are appearing in your local exam, for example in Pakistan, you can say कि आप ऐसे करके दिखा सकते हैं मुझे, और खुद आप elicit करेंगे. You will just spread out your arms straight with the palms towards the ceiling. ठीक है. और फिर आप पेशेंट से कहेंगे just close your eyes, अपनी आंखें बंद कर लें, and in 1 to 2 seconds, I think 1 to 2 seconds is a bit more, in just 3 to 4 seconds you will assess that okay, patient has good power, his arms are not going down. Okay. Or for example, if he has low power or towards one side, for example if it is a case of hemiplegia, then you can say that pronator drift is positive and patient has right upper limb weakness as well. Okay. Or it can be a case of quadriplegia or quadripresis. If it is quadriplegia, patient won't be able to do. If it is quadripresis, both of his arms may go down. If command is do motor cranial nerve, which relevant should be done? Okay, motor, after doing motor cranial nerve, the foremost relevant is other cranial nerves. Then your relevant examination will go according to your findings. For example, if you find something abnormal in the eyes, for example it is sixth nerve palsy, or it is, for example let's say it is sixth nerve palsy, then you can check for seven nerve. Okay. Why you will check for 7 nerve? Because 6 and 7 together can come in the form of Millard-Goblet syndrome. After 7 nerve, you will go towards the upper limb, you will do pronator drift, you will do the planters, you can assess the gait of the patient after assessing the power. So according to your case, then again, if you are able to do pulse, if you are able to do the precordium, well and good. Usually at the end of the examination, no time is left to say, I would like to complete my examination by doing MMSE or examining upper limb, then what to do and what to tell relevant examination like pulse, bruit, precordium in case of stroke. No, I was just saying that at the end of your examination, when you are coming towards your seat, towards the examiner, then you will say, and it will not take more than 5 seconds. Okay, bell will ring, the examiner will say, okay, doctor, come. In order, sir, in order to complete my examination, I would like to perform the gait of this patient, do the fundoscopy, and assess the cranial nerves. It will not take more than 5 to 10 seconds. Okay. I hope it is clear. Any other question? If there is no other question, then let's move towards the next part. How to check cortical sign? Okay, cortical sign, the foremost thing is patient cannot speak, or patient has dysarthria, patient has aphasia. The foremost thing, patient cannot see anything, it is the lesion is in the cortex. Or you can say that patient has astereognosis. You will just hand over the patient the key. For example, in case of FCPS, you have the key in your examination kit, you will hand over the key to the patient, or the coin to the patient, or your pen, and you will say, okay, what is this? He will say, he will not be able to assess by closing his eyes. Okay. And you have to hand over that thing to the patient towards the side of the weakness. Okay. Or you can just write 1 or just write 0 on the hand of that patient, and you can assess that patient has the cortical sign positive. 2-point discrimination, again you can check on the, I think it is on the fingertips, that there are different values. Basically you need to uh, go in detail somewhat. You can say if you are appearing in the FCPS exam, it can come in your long case, the examiner might ask from you. But in case of PACES, I would suggest no need to go in much detail, and because there is no much time in your short case to assess the cortical signs. Okay. Instead of assessing the cortical sign, you can check for cranial nerve, you can check for pulse, you can check for nicotine staining, finger prick mark, precordium, which are the risk factors of stroke. All right. If flaccid paraparesis, if flaccid paraplegia, then should we do the back examination and cerebellar sign? एक minute, where is the question? If flaccid paraplegia, then should we do the back examination and cerebellar sign? Why, doctor? I don't understand what differentials are you thinking about? Ma'am, if in cerebellar sign only finger nose test positive and rest of cerebellar signs negative, then will it consider cerebellar lesion? Uh, if it is cerebellar lesion, then and finger nose test is positive, then you will have some other sign, doctor. For example, in cerebellar lesion, there will be hypotonia, okay, and there is pendular knee jerk. There will be ataxia when the patient will walk. There will be wide based gait. There can be nystagmus in his eyes. All right, and cerebellar lesion do not come so alone. There will be some other cranial nerve involvement. There might be some other cranial nerve involvement as well. There will be intention tremors. Okay, any other question? Or I will stop the recording and I just want to show you some videos, and then you people can participate and you can tell what sign this patient is showing. All right. Dr. Faiza, are you there?
Yes, Dr. Mubashir.
If command is upper limb examination, should we check lower limb too? Yes, doctor, you will check, na? Because just try to make your examination or your scheme so fluent that you would be able to complete at least you can touch the plantars, you can touch the tone or reflexes or whatever finding you get in the upper limb. Okay, you should check. Okay, doctors, now I am stopping the recording and then we will move towards the next part.